So welcome to today's series. We'll be talking about cavernomas. So what it is, the pathology of it, how we diagnose it, and what do we do about them. So starting off with an overview, what are cavernomas? So cavernomas are a benign vascular hamartomas. So they consisted of thick and thin vascular channels within the brain. So it's just an abnormal group of vascular channels. And the problem with cavernomas is that they can bleed, and when they bleed, they can cause symptoms. On their own, they can also cause symptoms, which we can talk about. Some of them can calcify and have calcium deposits, and some of them can thrombose as well. So they do have a lichened appearance to a mulberry, and when we put it under a light microscope, we do find that the smooth muscle layer within the actual channels are absent. In general, when we think about central nervous system, all the different types of vascular malformation, they consist about 5 to 13%, so a significant proportion of it. But it's only really present in about anywhere up to 0.16% of the population. So it is a rare type of condition. Most of them are supratentorial, so above the tentorium. About 4 to 25% are in the brainstem itself, so on the base, and about 5 to 10% in the basal ganglia, so within the deeper portions of our brain. This is important because when it does bleed, it can cause damage or swelling around the local area. So if it's somewhere supratentorial, let's say in your frontal lobe, it's less risky in regards to the different types of symptoms that you can get compared to something in the brainstem where there is all the structures that control your face, neck, vision, swallowing, speech. So it can present quite drastically. We do know that some of these cavernomas do have a genetic hereditary form as well. So most of people present with seizures just because of the location itself can be irritating to the brain. If they bleed, they can also leave a hemosiderin ring around them, and that itself can cause seizures. Hemorrhage, as we can talked about, so bleeding, so they can bleed within itself. Focal neurological deficit, even without the evidence of bleed. And some of them are actually just found incidentally. So when we scan the head for other reasons, we sort of pick them up by accident. So pathology of it. So here is a picture of a histology slide. They're sort of made up of these dilated vascular channels. They're lined by these very thin endothelial cells, and you can see throughout the slides that there is a lack of actual smooth muscle cells. And because of this, they're much more weaker, and thus they're more likely to bleed. Now, in regards to how they form, we found that there are some genetic components to it, some mutations in chromosome 3 and chromosome 7, particularly the CCM 1, 2, and 3 genes have been implicated in the form. So, and you do find they have multiple cavernomas or a family history of them, you can send them off to genetics to get them screened. And if they do have genetic mutations, it can help screening for their family members as well. So, what is the risk of hemorrhage? So, if we find a cavernoma and by accident, the risk of it bleeding is actually less than 1%. However, if it's already bled, it puts them at about 5 times higher risk. If it's in the brainstem, it's about 4.4 times the risk. Of course, the annual risk of it bleeding again does decline over time, and we find that the bleeding rates do have higher rates with familial causes rather than sporadic causes. And we don't have strong evidence to support that pregnancy, blood thinners, or any physical activity increases the risk of bleeding. So how do we diagnose them? So CT is not very sensitive. It can miss very small lesions. And of course, they have overlapping appearances with like low-grade tumors, different types of bleeds and granulomas, etc. So here on the scan, you can see on the right side, We've got this hyperdense lesion. You can see this focus of calcification, this really bright spot. So it's really hard to tell if this is really cavernoma or bleed or it could be a lesion. So really, the next step would be an MRI scan. So MRI is the diagnostic test. SWE is the best sequence to diagnose it. So susceptibility weighted imaging or T2 weighted imaging. It has what we call a popcorn sort of appearance, a bit hard to discern. Sometimes all these cavernomas can have venous malformations that are sort of adjacent to it, so large draining veins or developmental venous anomalies. And then diffusion tensor imaging in terms of tracts can help with localizing where the lesion is, approaches, and different operative outcomes. It is not really routine that we scan the spine as well, unless if the patient actually has sensory, motor weakness or some sort of pathology that we can correlate with the spine itself. If we do a cerebral angiogram, it should be occult, so we shouldn't see a cavernoma um, light up on an angiogram. Now, in terms of evaluating and treatments, so there are a few recommendations that I found. Mainly, I've taken this from Greensburg, which is a great book in terms of outlining the different treatment modalities. So, if a patient is asymptomatic, has no symptoms, surgery is generally not recommended. But if it's really easily accessible, so somewhere that you can access it, if it's not an eloquent brain, so eloquent brain refers to areas are very important. So motor, sensory, vision, speech. So if it's not in those areas, and if it can help prevent future bleeds or the psychological burden of a patient needs to be on blood thinners, then it can be considered. If the patient's having seizures, especially if it's refractory to medications, then early cavernoma resection can be warranted. Um, if it's in the brainstem and they've had second symptomatic bleeds, it can be considered on a case by case basis. So here's like an example on the side of a cavernoma in the brainstem. So brainstem has a lot of cranial nerves, controls your respiratory drive, and is quite vital for many of our function of daily life. And thus, operating in this region carries very high risk. Um, so thus we usually wait until a second bleed. And of course, if the first bleed is very disabling, the indications for surgery can also be weaker. Generally, we wait if it bleeds, it can somehow exit or make an entrance to the outside and form a path, and that can help guide surgery in terms of approach. Because if it hasn't created a path to the outside, then you will have to be damaging structures along the way to access it. So it does place it at a much higher risk. Radiation can be considered if it's in an eloquent area, so a very important area, but it's important to know that radiation can actually form cavernomas on their own. Surveillance, so sometimes we can just do nothing and we just watch with time. So, especially people that have no symptoms, you can just try to follow them for about 2 to 3 years minimum, just to monitor that they're not having any bleeds without any symptoms. So, subclinical bleeds. And then brainstem bleeds as well, especially first time if they've bled, and especially those that do not have come to the surface, like I talked before. So if it's a superficial brainstem bleed, the chances of us creating neurological deficits about 9% versus about nearly 30% if it's a deep brainstem. It's important to know that with brainstem cavernoma surgery, the risk of short-term neurological deficits is about 50%, so very significant. And most of the approaches is infratentorial through the back, as you can see here. In terms of surgery, we consider it, as we talked about before, if it's accessible, if it's caused the patient focal deficits, bleeds, seizures, or if it's even if it's less accessible, if it's repetitively bled and they've progressively neurologically declined, then we can access it. So here is an example of a surgery where they're making a craniotomy and they've cut the dura and entered where they've taken the cavernoma out. It's important to sometimes if it's in a not an eloquent area, you also have to remove the hemosiderin ring as well. You usually try to take it as a piecemeal pattern in terms of taking it out. And it's important not to disrupt if there's a large draining vein or developmental venous anomaly to not disrupt that as well. Radiation is controversial. It has shown to decrease in recurrent bleeding rate, but there's a time delay for effects. So it does take a number of years. It can even take a number of years for it to take full effect. And also, we know that it has the potential to form cavernomas. And prognosis, so if a cavernoma is fully removed, the risk of further growth or bleed should be zero. But if it's partially removed, there's a potential for recurrence of symptoms. So that concludes the whole talk. Hope that was useful. Let me know what you would like to hear next and stay tuned.